How to critically examine a patient in the golden hour of trauma? This is a question I used to have often being a trauma surgeon until I found a code of conduct. But for that, first of all, assemble a team and explain them properly how to anticipate and what to perform. Most of the issues are created when suddenly few patients come and nurses don't know what to do. Thus, planning is important. Also, the goal is to achieve the maximum in whatever resources you have. It reminds me of the Parishs 80-20 principle, and these principles are applicable to even the poorest countries. It all starts with a good medical history and mechanism of injury by the paramedics who have to make a call where to transfer the patient. Treatment of seriously injured patients require the rapid assessment of injuries and institution of life preserving therapy. Because timing is crucial, a systematic approach that can be rapidly and accurately applied is essential. The primary and secondary surveys should be repeated frequently to identify any change in the patient's status. In an actual clinical situation, many of these activities occur in parallel or simultaneously. The longitudinal progression of the assessment process allows the clinician an opportunity to mentally review the progress of an actual trauma resuscitation. During the pre-hospital phase, emphasis should be made on airway maintenance, control of external bleeding and shock, immobilization of the patient and immediate transportation to the closest facility, preferably a verified trauma center, should also be taken into consideration. Mechanisms of injury can suggest the degree of injury. Triage involves sorting of the patients based on their needs for treatment and the resources available to provide that treatment. It is the responsibility of the pre-hospital personnel and their medical directors to ensure that the appropriate patients arrive at appropriate hospitals. In such situations, patients with life-threatening problems and those sustaining multiple system injuries are treated first, asking the patient for his and her name and asking what happened, etc. An appropriate response suggests that there is no major airway compromise, that is, the ability to speak is clear, breathing is not severely compromised because the ability to generate air movements to permit speech is present, and there is no decrease in the level of consciousness, that is, the patient is alert enough to describe what happened. During the primary survey, the life-threatening situations are identified in a prioritized sequence. For example, airway compromise can occur secondary to head trauma. Injuries causing shock or direct physical trauma to the airway. To perform effectively, the members of a team must constantly communicate with each other under a team leader. Patient population that warrants special consideration are children, pregnant females, older adults, athletes, and obese individuals. Although the anatomical and physiological differences of pediatric differ from adult, the quantities of blood, fluid, and medication, basically the size of the child, degree and rapidity of heat loss, injury patterns probably may differ. Priorities for the care of pediatric patients still remains the same. In pregnancy, the anatomical and physiological changes can modify the patient's response to injury. Early recognition of pregnancy should be done by palpating the abdomen for a gravid uterus. Laboratory testing of human chorionic gonadotrophin should be done, which is HCG, and early fetal assessment are also important for maternal and fetal survival. Resuscitation of older adults warrants special attention. The aging process diminishes the physiological reserve of an elderly trauma patient, and also a chronic cardiac, respiratory, metabolic diseased patient can impair their ability to respond to an injury in the same manner as an younger patient. Medical comorbidities and long-term use of medications can alter a usual physiological response to injury, and frequently it leads to over-resuscitation or under-resuscitation in the patient population, and early recognition of it can improve the survival of this patient. In obese individuals, intubation is difficult sometimes. Also, ultrasound doing or diagnostic peritoneal lavage, CT scan may also sometimes be difficult. Before my basic ABCDs, I do order a simple IVOT O2 monitor. That is how I remember it. It is easy. We are treating a critical patient, so we treat it with intravenous fluids. Like every trauma patient requires O2 also, and also it requires monitoring. Coming back to our ABCs, A stands for airway. We need to do a thorough assessment of it to rule out any severe injury that may prevent the later transfer of oxygen to the body, as per like a head, cervical, maxillofacial or a chest injury causing deterioration. Assessment for signs of airway obstruction should include suctioning and inspection for foreign bodies. Initially, the chin lift or a jaw thrust maneuver is recommended. To achieve airway patency, probably patient with a severe head injury who has an altered level of consciousness or a Glasgow Coma scale of 8 or less usually requires a placement of a definitive airway. When it comes to discussion of a definitive airway, it is actually meant in different terms, but it is actually a cuffed secured tube in the trachea. Care should be taken to prevent excessive movement of the cervical spine. Loss of stability of the cervical spine should be assumed in all trauma cases. Initially, protection of the patient's spinal cord with an appropriate immobilization device should be accomplished and maintained. If immobilization devices must be removed temporarily, one member of the trauma team should manually stabilize the patient's head and neck, and also the cervical spine radiographs must be obtained to confirm or exclude injury. Equally important is the necessity to recognize the potential for progressive airway loss. Pitfalls in airway are that there are circumstances in which airway is exceptionally difficult. Equipment failure often cannot be anticipated, like the lights of the laryngoscope may burn out. Endotracheal intubation of a patient with an unknown laryngeal fracture or an incomplete airway transaction can precipitate a total airway occlusion or a complete airway transaction. An airway should be established surgically if intubation is contraindicated or cannot be accomplished. In the breathing portion, we see for breath sounds and the oxygen saturation by a pulse oximeter. If the patient is crashing on his oxygen saturation, we suspect it to be a tension pneumothorax or a hemothorax. In that case, we pass a temporary needle in the second intercostal space mid-clavicular line and then replace it by a fifth intercostal chest tube. This measure is definitely life-saving. This concept is that the adequate gas exchange is required to maximize the oxygenation and carbon dioxide elimination. The patient's neck and chest should be exposed to adequately assess the jugular venous distension. Also, the position of the trachea and chest wall excursion are important. Auscultation should be performed to ensure gas flows in each lung equally. Visual inspection and palpation can detect injuries to the chest wall like tension pneumothorax, flail chest with a pulmonary contusion, a massive hemothorax, and an open pneumothorax. The pitfalls are like differentiating between a ventilation problem and an airway problem. It may be difficult. Patients who have profound dyspnea or tachypnea appear as though their primary problem is related to an inadequate airway. However, if ventilation is the problem, like a pneumothorax or a tension pneumothorax, intubation with a vigorous bag mask ventilation can rapidly lead to a further deterioration of the patient. Thus, a chest X-ray should be obtained as soon as possible after intubation. For now, I end this section here. In the next section, we will be describing the D, that is the disability onwards portion. If you have any queries, insights, or experiences, please feel free to write in the section below. If you like this video, give a thumbs up or subscribe to the channel for more of such videos.